Morning, good morning, good morning. And welcome to another CME session brought to you by your continuing medical education department. This morning, we are so excited that you joined us and extremely excited for all of those who were able to catch our early bird session. I truly hope that you got your brain cells fired up and you are ready to go for this morning's presentation. We have an exciting presentation for you this morning, and it is being brought to us by our very own Dr. Marcus Cooper. For those of you who may not know who he is, I will briefly remind you. But before we do that, we will open up in a word of prayer as we usually do. Father God in heaven, we thank you so much for this day. We thank you for life. We thank you for strength. We thank you for an opportunity to share with each other as colleagues, an opportunity to serve you through serving others. We pray, oh God, that we take that responsibility very seriously, and we pray that the information provided to us will be a tool in helping us to fulfill that mandate. We pray all of these things in no other name but the name of Jesus Christ, our Lord and personal Savior. Amen. Dr. Marcus Cooper is a gastroenterologist and internist who received his tertiary education at the University at Albany, where he got a Bachelor's of Science in Biology in 1992, a MBBS from the University of the West Indies in Augustins, Trinidad and Tobago in 1998, and subsequently a Master's in Health Administration from Florida International University in Miami, Florida in 2005. Dr. Cooper began his clinical training as an intern at the Princess Margaret Hospital, Nassau, Bahamas, 1998 to 2000, and went on to specialize in internal medicine and gastroenterology at the University of Miami Jackson Health System, Miami, Florida, where he completed his training in 2009. Dr. Cooper was previously a clinical instructor in the Division of Hematology and Oncology at the University of Miami Hospital and Clinic's Sylvester Comprehensive Cancer Center from 2003 to 2006, and is currently a consultant in the Department of Medicine at the Princess Margaret Hospital. Dr. Cooper has served on numerous boards and councils, including the Health Facilities Board, Pharmacy Council, and the Board of the National Health Insurance Authority. Has been the past president of the Medical Association of the Bahamas. In his professional experience, Dr. Cooper is the CEO and medical director of GastroCare Bahamas, an outpatient endoscopy center. He has published several papers and have been involved in a whole host of other civic organizations. So I invite you this morning to welcome Dr. Marcus Cooper, who will be speaking to us on non-ulcer dyspepsia, the gas epidemic. Dr. Cooper?
Good morning. Can you hear me?
Yes, we can.
Are you getting any feedback?
No feedback.
Okay, good morning, colleagues. Thank you for joining and thank you for that exciting introduction. I don't know if I can make gas and bloating exciting, but I'm going to try. Okay, let me know if you can see my screen.
Not yet. There we go. You can open it. You can open it to.
Is it in full mode or is it in presenter mode?
It's in presenters mode at this time.
Okay, so how can I switch that? What about that?
No, just seeing you now.
Oh, we don't want that.
Okay, there we go.
Is that a full view?
Go to your next slide. Let's see. Okay, yeah, you're in full mode.
Okay, good morning. Somebody has their microphone on, sorry. Okay, so I'm going to spend a few minutes talking about dyspepsia. Not a very exciting topic, but a very common one. This is gas and bloating. This is what every single patient, in my opinion, at some point has a problem with gas and bloating. I don't care if you're in primary care or if you are in neurology or neurosurgery or podiatry or anything in between. Bahamian patients always seem to have an issue with gas and bloating. And I've seen quite a bit of variety in the way that physicians manage gas and bloating. And so I'm going to try to bring some sort of structure to what may be useful to you in your practice. So this is what I'm going to be talking about today. Some of the definitions and terms associated with dyspepsia, the types, how your history and physical are extremely important in figuring out what is going on, organic causes, the role of H. pylori, which is really significant for the Bahamas, the role of endoscopy, so when you should refer to a gastroenterologist if you think that an endoscopy is necessary, and the management. And I'm going to start off with a case study. So can you still see my screen?
Yes, we can.
In full view?
Yes.
Okay. So I'm going to start off with a case study. And this is actually somebody that I saw on Monday. I had previously put in a case study, but this one seemed to be so much more relevant because this is probably what you see on a regular basis. So he was a 35-year-old male who came in with hypertension, dyslipidemia. Mentioned that he'd been dealing with some mental health issues, anxiety and depression. So he remembers eating at a restaurant last year in November, and afterwards had a few days of upset stomach, some loose stools, a bit of nausea, but no vomiting. And now, some 6, 7 months later, he's having burning in the upper stomach, abdominal discomfort. He feels bloated, particularly after meals. Surgical history is positive only for spinal fusion. He's on medications for his blood pressure and his anxiety, and also gabapentin for back pain, neuropathic back pain that he gets as a result of his surgery. Occasional drinker, he doesn't smoke, no marijuana, which I would really advise everybody to take a cannabis history. People nowadays will not often volunteer when you ask them if they smoke, but if you ask them if they smoke weed, they will. And he drinks Coca-Cola daily. Ooh, what did I do there? Can you still see my screen?
No, it's gone.
How's that?
And you're back.
Okay. So on examination, he appeared comfortable. Blood pressure was okay. Overweight, BMI of 31. Abdominal organization, like the abdominal evaluation examination, just some mild discomfort in the epigastrium on palpation, but no masses were felt. So let's talk about dyspepsia. Dyspepsia is what the patient will say is gas and bloating. We in the medical community should define it as dyspepsia. Comes from the Greek word that means bad digestion. And these are the symptoms that people are going to complain about. This is from the Rome 3 criterion. If you know about the Rome uh, diagnosis, book of diagnoses, these are all functional problems, gastrointestinal functional problems. So functional as opposed to structural, where you can actually see something that's wrong on a CT scan or an MRI or an X-ray or an ultrasound. Functional problems, you can't see it. And these are usually hypersensitivity type reactions that happen in the gut. But people with dyspepsia will complain about postprandial fullness. So after they eat, they feel bloated. Bohemians will say, I feel bloated, I feel distended. Early satiety means that you eat a little bit of food and you feel full. And this is very different from the person who has gastric cancer, where, sometimes they vomit, they're losing lots of weight. But this is the person who, used to eat a plate of rice and now they can only eat a half a plate of rice because they feel bloated. Epigastric pain, which I would really challenge, because most patients don't complain about pain, they complain about discomfort. And if you ask them to differentiate between pain and discomfort, they'll say, well, it's not really painful, but it's uncomfortable. If it's real pain, you got to start thinking about something else. Because I believe I am not a believer in gas causing people to come to the hospital. I don't ever think it should be that bad. So if a person comes to A&E and they tell you they have abdominal pain, I think you should really start looking for an organic cause. And an epigastric burning is another frequent complaint, of burning sensation in the upper abdomen. So what are the different types of dyspepsia? Well, you have, and this is important for when you're speaking to your colleagues or when you're referring a patient, what type of dyspepsia do you think is going on? So uninvestigated dyspepsia is what happens when the patient comes to you in primary care. Nothing has been done. They're complaining about symptoms. They haven't had any imaging. They haven't had an endoscopy. You don't quite know what it is. So this is uninvestigated dyspepsia when the symptom complex aligns. Organic dyspepsia, this usually is a diagnosis that's made after an endoscopy. There's a clear cause, there's a peptic ulcer, there's a gastric mass, there's a hiatal hernia, something that's structurally seen that you can probably do something about. Non-ulcer dyspepsia is the category of dyspepsia where you've done an endoscopy, you see absolutely nothing. You do biopsies, there's no H. pylori, but the patient still has symptoms. And this is the same thing as functional dyspepsia, which is going to be a part of my talk. So, how often does this thing happen? I mean, this is data from the US, difficult to assess, thought to be fairly common. Annual incidence of 1 to 6%. I don't really know what that means, but for sure, I would agree that dyspepsia in the Bahamian population seems to affect women more often than men. And so this is from my own personal experience. If I were to say or try to comment about the epidemiology of dyspepsia, gas, and bloating in the Bahamas, I would almost say everybody has it at some point in their life. Extremely common. For the people who come to see me without a referral off the street, 50 to 60% of these people have some sort of dyspepsia, and that's their primary complaint. It seems like it dominates your practice, either dyspepsia or constipation, for many of your days. Females greater than males, I would absolutely agree with that. This is prime. Men don't seem to care that much about gas and bloating, and maybe they just don't like to complain. But women will definitely come in and complain about their symptoms and kind of want to get a better handle on it. And I would say that this is a disease of younger people. The older your patients get when they start complaining about these symptoms, especially if they're new, you should be suspicious and consider further workup. So your history and physical, I think, is most important in these patients. Um, Although it's very tedious, particularly for the GI people, because it seems to be like this is what you're seeing every single day. The history and physical can really help you to figure out, is this real dyspepsia or is this something else? So one of the first things you want to ask the patient is to where do you have the pain? And I ask my patients to point, where do you feel this pain? Watch the hands. The hands a lot will tell you where the problem is coming from. You all remember from embryology about foregut, midgut, and hindgut. And I find that this is extremely useful in lots of GI complaints and trying to figure out where the problem is and what diagnostic modality you should use to figure it out. So if the patient is kind of pointing to their chest and they're doing this up and down motion, um, retrosternally, that's reflux, right? That's not probably not dyspepsia, although dyspeptic symptoms may be contributing, but that patient is probably telling you that they're having acid reflux, and your investigations and treatment should be directed toward a person with acid reflux. When they're pointing to the upper abdomen, just above the navel, you want to start thinking about dyspeptic symptoms or something in the stomach. If it's below the navel, and we know that's the hindgut, then this person, even though they might be describing it as dyspeptic symptoms, you might want to start looking in the colon or something a lot lower down. So watching the hands can really help you a lot. Lots of these patients, well, I shouldn't say a lot, but at least 20% of these patients will have some reflux disease who are complaining about dyspeptic symptoms. And some of them will have really bad erosive esophagitis. So watching the hands and trying to tease out where the problem is becomes very important. The next question I ask is, what are you eating and drinking on most days? Like, what's your routine? And I'll ask them, if it's a Monday, what did you have for dinner? And what did you eat on Sunday? From the morning until the afternoon. And was your pain worse before or after meals? And a lot of times you'll find that Bahamians are just eating garbage, right? So this is a typical way that Bahamians start their day. And some of you have had this already. Um, at the top, and I want to make a distinction for what you see there at the top of your screen. This is not your like basic American sausage. This is sauchis. And sauchis is very different from sausage. And I actually got a 5 pound roll of this stuff and look at the ingredients. And the amount of salt and fat in these things is really astronomical. But people are eating this way, and you got your corned beef and your grits, and you got to make sure it's swimming in the grease. That's always necessary. Um, and your tuna with lots of mayo. So this is kind of like the beginning of the day, and for a lot of people, this is every single day. And then we follow that up with some But there's the sawchest right there. I know I had it somewhere. Um, Let me follow up with this. You got to have your fast food because you're on the run. You got to get your crock kunk or your chicken in the bag where the grease is seeping through. And then, your basic Bahamian lunch or dinner. You got a little bit of vegetable there. I think there's a lime in the back there, which would constitute as maybe a fruit or vegetable for balance. But this is what people are eating every day. And when you start to question them, there's no surprise that these people are coming in with dyspeptic symptoms. And of course, they will all tell you, Doc, I don't really eat that bad. So I ask people, what are you eating every day? And that's where I begin my assessment of possibly where this is coming from. Here are some other things that I found in my practice to be really, really helpful in eliminating to reduce symptoms of dyspepsia. Coffee. Caffeine in any form, I think, is a major contributor. And lots of times, just by asking the patient to come off of caffeine for 2 weeks, they will see an improvement in their symptoms. And this is something that happened to me personally, which caused me to start asking other people, and it seems to be consistent. Coffee, some people drink coffee once, twice, 3 times a day. Um, when you're younger, I think you can tolerate it, but for some reason, as people get older, caffeine seems to be more of a problem. You get caffeine in sodas as well. So you have to ask about that. You have to ask about chocolate intake because there are patients who consume enormous amounts of chocolate. So caffeine, I find, is a really big instigator. Dairy, people usually will know about. They know that if they have dairy, if they have cheese or milk or whatever, they get this, bloating and bubbling and sometimes diarrhea. Usually they will avoid it, but sometimes people just don't know. And then the saturated fats or the fast foods that we just talked about. So then I ask them about medications and supplements, and I will sit there and I will go through all of the medications that they're on, and I will Google each one of them and see what the side effect profile is. We know about NSAIDs. We know about how it causes damage to the gastroesophageal lining, um, and the rest of the GI tract. So I'll always ask about aspirin, and not just aspirin. I'll go through the list: aspirin, Motrin, Aleve, ibuprofen, Excedrin, even BC powder that people used to use back in the day. Some people are still finding that, and they're consuming these things for back pain or knee pain or arthritis or whatever the case may be. Uh, Highly, highly predictive of some sort of erosive gastritis or even a peptic ulcer when patients are on NSAIDs on a regular basis. And the higher the dose, and this also includes the COX-2s, right? So we know that our Coxia and Celebrex have a lower risk of forming peptic ulcers, but it's not um, absolutely excluded. So these patients are still at risk as well. Here's a list of other things that you might want to be aware about. Plavix, particularly when in combination with aspirin, is a big thing. Steroids, I think most doctors will put their patients on a PPI when they're on a long course of steroids, which is probably wise. We talked about the NSAIDs. Antibiotics, and this is interesting because particularly the ones that we use to treat H. pylori are the ones, the macrolides like clarithromycin, metronidazole that sometimes we'll use in people with penicillin allergies. These things can wreck the stomach. And the patients will tell you that was the most difficult course of antibiotics that I've ever taken in my life because it's two of them and you have to take it twice a day. Calcium channel blockers, I was not personally aware of. I think they're relatively safe, but people may complain. Iron supplements also will cause lots of discomfort in the stomach. These are some of the other things that I have identified during my practice that I've had to call the primary and say, look, can we take this person off of this medication for a few weeks to see if it improves their symptoms? Highly active antiretroviral therapy. Metformin is a big one. Patients on glucophage, they start it, they get a little bit of upset stomach and loose stools. You double the dose and control their diabetes. They're having lots of problems, and then trying to take other things to fix the problems. Some of your rheumatological drugs like methotrexate, the GLPs. Everybody's on a GLP. Every single one person is on a GLP, if you ask me. They're not going to tell you that, but they are. And we know that the mechanism of action of these things is to delay gastric emptying, which can cause nausea, an upset stomach. And don't want to forget the turmeric either. Lots of people, claim that there's a benefit to turmeric, but if you are using it on a consistent basis, I've had multiple patients come in complaining about this burning sensation in the stomach. You stop the turmeric, it goes away. So what about H. pylori? So H. pylori is a really big problem in the Bahamas, a lot bigger than I think we realize. And the association with dyspepsia is pretty high. And in national and international guidelines, you always have to rule out the presence of Helicobacter pylori. So we all know it's a gram-negative bacteria. It attaches itself very, very well uh, to the surface epithelium of the stomach using these adhesions. It releases toxins, and these toxins are responsible for the damage and the ulcers that sometimes result from H. pylori infection, and then chronic inflammation can go into gastric cancer. It also releases these cytokines, and the cytokines increase inflammatory mediators to the site. So these things can really cause lots of problems for people when they have it. The majority of people with H. pylori will be asymptomatic, but there are those who will develop symptoms and you have to exclude it. Why are we having such a problem with H. pylori transmission? Well, this is how it spread. People to people, um, oral. This is how we have young kids who've been diagnosed, and we had a study that was done here that I'll mention in a bit, in primary school children at a public school, and the H. pylori rates were very high. So we think that there is some oral to oral from mother to child. There's fecal to oral, um, what people do out there, contamination by food and by water supply. And so this is like a pervasive organism that seems to be spreading throughout the country. Um, National guidelines recommend that persons under the age of 60 who come in with dyspeptic symptoms, they're coming to you in primary care, it is reasonable and recommended to screen them for H. pylori, particularly in areas where the prevalence rates are high. So we know from our very own Dr. Floyd Carter in 2011 and 2012 that seroprevalence um, in adults, almost 60%. So these were all comers to the blood bank who were donating blood. They checked them to see if they had H. pylori antibodies, as the IgG. 58% of them did. And internationally, we know that seroprevalence, this is how they check for seroprevalence. Doesn't necessarily mean that you have an active infection, but you may, but you've been exposed and have had an infection before if your H. pylori antibody is positive. And then the presence of the H. pylori infection in children, this was done at a public primary school. I think there were 88 children that they asked to do this breath test, and these kids, 54% of them came back positive for H. pylori. So these are asymptomatic infections in many people, particularly in children, but it is pervasive. So we're looking at our prevalence rates of 50 something percent. And when we compare it to the rest of the world, that's pretty high. So I think the ones in red are greater than 70% prevalence. So you see some places in Africa, like South Africa, and I think Ghana, and then in a couple of places in South America. Um, uh, these places have really high rates. Um, but in red, sorry, in purple, which is where we would fit in, um, uh, the Bahamas is holding its own. And you can see that in India, where we know about the sanitary or the unsanitary conditions that you see in India, for some reason, even though we'd like to think that we're a lot better, H. pylori, which has been associated with poor sanitation and poor quality water, is just as high in the Bahamas, which I find to be really alarming and something that we need to do something about, particularly because of the associations with gastric cancer. So this is my theory of why our H. pylori rates are so high. So you all start to see the crabs come out. Father's Day is coming, and that's how you know the crabs. And I believe that in the Bahamas, crabs are vectors for H. pylori. And you may not want to believe it, but I'm going to prove it. And I've actually sent samples of crab meat. I wouldn't say, I'm not going to call any particular island, but I've sent Bahamian black crab meat to the lab to be tested for H. pylori. And I didn't tell them what it was. And so they asked me, like, what is this? Like, this does not look like human tissue. So I was trying to get one over on them to see if they could test it for H. pylori. They couldn't, but I'm working on it because I am so sure that Bahamian crabs, purged or not, are a source of H. pylori. The second one is contaminated water. So we know globally that the water supply can be a source of H. pylori. And I took this picture from a report that was released in 2004 when the U.S. Army Corps of Engineers was here, and they did a study on water resources in the Bahamas, and they visited like about 12 or 13 islands, and they talked about the threats to our water supply and pollutants, and they talked about how our water table, particularly New Providence, is within 3 to 6 feet, right? So if you dig a well in your backyard, which I've done recently, uh, before you hit 6, 7 feet, you're going to hit water. And so the water table is pretty high. And back when we were having a lot of talk about shanty towns, you can see on the left of this picture, and I stuck that in there. But when you have these shanty towns without proper waste disposal, and they build these pit latrines, how you can get contamination of your water table very, very easily. And even though the issue with shanty towns and stuff was a real political football, it really suggests that this could be a major public health issue that needs to be addressed because there are very few countries in the world that have H. pylori prevalence rates higher than the Bahamas. And one of them, and I think the highest that I've seen in my research, is in Haiti with seroprevalence rates of close to 90%. So you can see that if in our shanty towns that our neighbors to the south are the primary inhabitants of these shanty towns and don't have proper running water and don't have proper sewage disposal, how our water table could be severely contaminated. And so, I've been speaking to some people at Water and Sewage. You think that, because they check the water, they'd be able to identify this. But identifying and isolating H. pylori in the water is not as simple as just sending it to Water and Sewage or to Aquapure for testing or the water lab. It's a much more complex procedure to isolate H. pylori in the water. So I think that this is what's contributing to our high rates of H. pylori, and hopefully we'll have some data in this soon. If you're interested in some research, hit me up so we could do some stuff. So you would think that, when people come to you with these dyspeptic symptoms, it is reasonable to check them for H. pylori, because of our prevalence rates, it really is. So I actually looked at this in my practice to see how many people coming in with gas and bloating and burning actually had H. pylori. And you got a 50% chance. They were out of 200 and something people, there were 42%, and Gary De La Rota and I presented this at Research Day, I think 2 or 3 years ago. So 42% of the patients were positive, which means that, doing it is a good idea. And the chances are that if you find it and treat it, a lot of these patients, at least almost 50% of these patients, will get better. So how should you test it? So I don't want to say anything bad about the H. pylori serology that many of us do. I mean, it's readily available if you do it. A lot of times these patients, they don't want to wait for no blood tests. They don't look at wait for no stool tests. They're having symptoms now, you got to treat them now. But you should be aware that your serology is the least sensitive at detecting H. pylori. One, because it doesn't tell you if the patient is actively infected, just tells you that they're exposed. And it's not as sensitive of a test as your stool antigen or your breath test. Stool antigen, getting it, it's cumbersome. Patients don't want to do that. Breath test is expensive. The GIs have it in their offices, but it can range, 150 to 200 something dollars. But if the diagnosis is in question, or the patient has had a peptic ulcer diagnosed, or they've had gastric cancer, then your serology does become important. This is just a diagram I thought explains that really good. They took 100 patients and they send them all for endoscopy. The patients had a CLO test. The CLO test is when you take a sample of the gastric mucosa, you biopsy it, you take that tissue, you stick it in a cassette, and you see if the cassette turns color. It detects a urease reaction, which we know the H. pylori bacteria can do, and it will turn color immediately. So you know that there's H. pylori in your sample. And then these patients were also subjected to a breath test as well as the blood test. So you can see on the left of the square, almost 50% of these patients were triple negative. So they didn't have a positive serology, they did not have a positive breath test, and they did not have a positive CLO test. So these are probably true negatives. The other 51% of these patients, you can see that 26%, that 26% of them would have had a positive IgG serology, a positive breath test, and a positive CLO. So they were triple positive. That's your true positives. CLO tests can be skewed by sampling error. So if you biopsy down low in the stomach and the H. pylori is up high, you may miss it, or vice versa. But these patients should be picked up by a breath test because it's a more complete assessment of the stomach. So you'll see that even though 26 were captured with the CLO, an additional 4 were identified with the breath test. But there were 21 patients who had serology that did not have a positive breath test or a positive CLO test. So there's a substantial amount of people who you will send for the blood test looking for the H. pylori antibody who will not have an active infection. And these patients will be subjected to the triple therapy or whatever type of therapy that you use, and you may not see an improvement, and that's because they don't have an active infection. So this is what we are currently using or should be using to treat H. pylori, and this is important that you get it right. I've seen lots of different voodoo type cocktails that patients have been on to treat H. pylori. This is what you should have been doing. So the triple therapy, the most common, your amoxicillin, chlorithro, PPI, and the PPI doesn't have to be 40 milligrams twice a day, even though that's what I give. It could be 20 milligrams twice a day. They have a penicillin allergen. You switch the amoxicillin for flagyl. That's the toxic one because clarithromycin and flagyl, you get the really metallic taste in the mouth. It upsets the stomach. Yada. So you can kind of, in some cases, you can switch the chlorithro for a fluoroquinolone like levofloxacin, which you only have to give once a day. The sequential 5 and 5, so it's a 10-day therapy, but you can give 7 and 7, PPI and amoxicillin twice a day, same dose, and then PPI with either chlorithro or metro twice a day, same dose. And this bismuth quadruple therapy, which most people don't use. Now, 2024, American College of Gastroenterology and the Canadian Association of Gastroenterology came out with new treatment guidelines for H. pylori. This should have been groundbreaking, but it just didn't seem to have the kind of ripple effect that I thought it would. But the reason they changed the guidelines is because of resistance patterns. Lots of resistance to clarithromycin. In the US, the amoxicillin resistant rates are not so high, but also lots of resistance to metronidazole. Now, if you look at this graph, clarithromycin rates in the US about 22%. Metronidazole resistance rates about 69%. Amoxicillin resistance rates very low, less than 5%. But even based on these resistance rates, they thought it was high enough, particularly for the clarithrol and the flagyl, to make sweeping recommendations about changing therapy. These are our resistance rates. This is from PMH and Doctors Hospital antibiograms. And I'd like to thank Dr. Edwards and Dr. William for providing me with this information. Our resistance rates make their resistance rates look like underachievers. Erythromycin, 54 to 60%, ampicillin, which is our surrogate for amoxicillin, 58 to 67%. For the penicillin allergy patients, you're in the 30% range. I mean, our bacteria are eating these drugs for breakfast, like sausages. And so we're probably not doing a good job of treating H. pylori and eradicating it. And it's the eradication that's really important to ensure that your patients don't go on to develop complications of H. pylori infection, like peptic ulcer, like erosive gastritis, like gastric cancer, malt lymphoma. These are some serious complications, and there are others. So for sure, if the U.S. changes their treatment patterns based on those, resistance rates, we should be doing the same. So this is what we should be using, right? You don't see the triple therapy anywhere in here. I'm going to not talk about the vonoprazan. These are a new type of PPI, these potassium competitive acid blockers. We don't have them here, so I'm not going to talk about it. So I'm going to talk about the optimized bismuth quadruple and the rifabutin triple, which is less likely to be used because I don't know if any pharmacies in the Bahamas carry rifabutin. So this is what we should be using. Your first line, PPI twice a day, 20 or 40, it doesn't matter. Bismuth subsalicylate, 300 milligrams, 4 times a day. Now, this is Pepto-Bismol, and me and my trusty pharmacist worked out what should be a 15 mils 4 times a day if you're using the liquid. The tablets are 262 milligrams, I think. So you can use like a tablet and a half 4 times a day, but it's probably easier and cheaper to use the liquid. Tetracycline, not doxycycline, 4 times a day. Flagyl, 500 milligrams, 3 times or 4 times a day. This is what you should be using. Now, if you've ever taken H. pylori therapy yourself, taking drugs 4 times a day is ridiculous, right? So I don't know why they recommend 4 times a day, but they're saying that eradication rates are much higher if you do it 4 times a day. That's tough. It's tough. I took it. I don't even know if I finished it myself. But you got to get your patient engaged, particularly if they're having lots of symptoms, to say, I'm going to finish this thing. Second line would be your rifabutin, probably a lot easier to take because it's 3 times a day, your PPI, 20 milligrams TID. Amoxil, 1 gram TID, that's a lot. And then your rifabutin, 50 milligrams TID. This might be an opportunity for some pharmacists to start to source this rifabutin so that patients have an alternative. So this is what we should be doing now. And if you look online and you look up triple therapy, you'll start to see less and less of what we would, if you look up therapy for H. pylori, you'll see less and less stuff talking about triple therapy because of these high resistance rates and more content, more journals, articles, etc., talking about this bismuth quadruple therapy. When should you test and treat for H. pylori? Diagnose peptic ulcers. This is even saying members of a household who've been diagnosed with H. pylori, not by blood, but by either breath or something, because it's spread person to person, fecal oral, oral, oral. Patients who are long-term NSAIDs, bad arthritis, rheumatological problems, rheumatoid arthritis or lupus or whatever the case may be. These people are on Arcoxia or some COX-2 for extended period of time, or people with cardiovascular disease who are on aspirin, even though we know that, you got to really individualize your aspirin therapy in this population. It's not one size fits all thing, but these are people who you want to know, do you have H. pylori? Because we know the combination of NSAIDs and H. pylori is bad news. Unexplained iron deficiency anemia, because this can cause anemia. ITP, you should always want to rule out H. pylori because it can drop your platelets. And gastric cancer and autoimmune gastritis, we know, is directly associated with H. pylori. What's the role of endoscopy? So patients are having severe symptoms, like they're having these alarm symptoms, so to speak. Weight loss and vomiting. You should never get vomiting with dyspepsia. Maybe nausea, but not vomiting. Severe weight loss, no. Anemia, no. For those of you out there who start people on iron, particularly older people above the ages of 50 or 60, and you don't know why, that is not good medicine. Iron deficiency anemia is not a diagnosis. It's a symptom. It's a complication. Find out why these people are anemic. If she's 30 years old and she's having menorrhagia, okay, that's fine. If she's a sickler or he's a sickler, that's fine. But if you don't know, and the patient comes to you with an HB of 8 or 9 or 10, you need to know. So send them, do some workup, check iron levels. If it's low, even if it's not low, send them over to GI, let us figure it out. Alarm symptoms. And sometimes the patients are all freaked out. They got, cancer in the family, and they say, look, I can't sleep unless I know that there's nothing going on. Then sure, we can do it. I'll skip over this because we talked about that. Um, I want to start looking at our gastric cancer rates, because if our H. pylori prevalence rates are in the 60%, 50, 60%, our gastric cancer rates should be increasing. And so we need to kind of look at this and be proactive as opposed to reactive. So going back to the case study, our guy, he had an EGD, he had mild gastritis, there was no H. pylori organisms identified. The dude still has symptoms. What do? He fits this criteria. Um, Bothersome postprandial fullness, the satiety, the burning. He had the EGD, no structural diseases. It's been going on for a few months. This is your classic case of functional dyspepsia. Um, uh, 40 to 60% of patients who have an EGD are not going to have anything. Upper endoscopies are the easiest ways to make money, because 90% of the patients, in my perspective and my experience, will have negative findings. And the ones who are going to have something, you can tell right away, even before you scope them. So mechanism of functional dyspepsia, this is same kind of thing as irritable bowel syndrome, this visceral hypersensitivity. A lot of these people are anxious, or they worry a lot. They got issues going on, like this particular gentleman did. Every single sensation is discomfort to them, and we know this from studies in the colon, where if you stick a balloon in somebody's rectum who has these hypersensitivity issues of their gut, and you inflate it with 10 mils of water, these people will have excruciating pain, whereas the average person will feel nothing, or just they'll just feel something, some tickle in the rectum. So we know that visceral hypersensitivity is a real thing in functional dyspepsia, as well as irritable bowel syndrome. So what do? I stress the caffeine thing. If you're on it, get off of it. Do it for a few weeks. And if you get better, at least you know that this is the problem. Then you can choose to go back on it or not. Reduce your fat intake. All this fast food stuff that people are doing definitely will cause your symptoms to be worse. The FODMAP diet, you could look it up, but it's all these things that have sugar in it that you can eliminate. I don't find the FODMAP to be particularly helpful because it's a diet, and nobody can stay on a diet forever. There are some people who have gluten sensitivity for real. They may not have celiac, but they have gluten sensitivity. They eat bread, they feel bloated. They eat pasta, they feel bloated. Other processed stuff, they feel bloated. these people, try them. Say, look, like, is bread a big part of your day when you're doing your dietary assessment? Let's try to eliminate all these sources of gluten. You tell them tell them Google gluten, and these are the things you should avoid. Do it for 2 weeks. Let's see if you get better. Probiotics, some literature says it helps, some says it doesn't, but it definitely can improve in patients who have H. pylori. There are studies that it shows that it improves the H. pylori eradication rate, particularly when you combine it with the newer therapies. These are some of the supplements on the market that you can offer patients. Um, I can't say that any of them is more helpful than others, but trial and error, because this is a functional problem. Um, the guidelines will say that you can try tricyclic antidepressants and psychotherapy. I think at that point you should just send them over to GI and kind of let us make that assessment to make sure we haven't missed anything. So if you look at the guidelines, this is pretty much what you should be doing in an adult over the age of 60, even without organic symptoms. If they are persistent, you want to take a look. You don't want to miss anything. If they're under the age of 60, you want to test and treat for H. pylori. If the patient doesn't want to wait, then it's reasonable for you to go ahead and treat them empirically, given our high seroprevalence rates. It's not necessary to confirm eradication with a test in all of these patients. The majority of them, you should reassess them after 4 weeks for symptom improvement, and that's enough. In people who have peptic ulcer, who have gastric cancer in the family, who have ITP, unexplained anemia, you want to confirm eradication, preferably with a breath test or a stool test. For those people who do not have H. pylori, you could put them on a trial of PPI. If that doesn't work, you could put them on a prokinetic like Motilium, which helps with gastric emptying, because some of these patients will have some delayed gastric emptying. You can try some tricyclic antidepressant for those people who may have functional problems. But I think this is something that your GI person should do. Thank you very much for your attention, and I hope that this was useful and something that you can start implementing in your practice right away. Any questions?
Thank you. Thank you so much, Dr. Cooper. It was a wonderful presentation indeed. It is something that we see very frequently out in the community, and I'm sure also in the hospital as well. So while our colleagues think about their question and or comments, some are coming in already, I would just like to draw your attention to the feedback for this presentation. It has been placed in the chat. Please ensure that you click on the link so that you can provide feedback for this presentation. For those of you who have joined with a name that is not the name that you are registered in at the Bahamas Medical Council, please ensure that you change your name to reflect the name that you are registered in at the Bahamas Medical Council. I want to encourage all of you to go back and watch all of the previous presentations that we would have done before, complete the feedback, because we do want to get your credits to you well ahead of time this year to meet your licensure requirements. Okay, we have Dr. Spencer Prince saying, thank you, Marcus. Excellent, needful presentation. Dr. Robinson, good morning. Thank you for this valuable information. Do you think, along with lifestyle changes, the addition on herbs, spices, vegetables, example, garlic, ginger, oregano, can help with symptoms and heal GI?
I would say yes. So if you have a patient who has been investigated, they don't have H. pylori, or they had H. pylori, you treated them, you've kind of gone through the elimination thing with the diet, and they're still having symptoms, and absolutely, I think there is a role for dietary suggestions. And if garlic and ginger and oregano can help, then absolutely. I mean, it won't hurt. So I'm all in favor of trying things that are plant-based. and that are natural, that don't have side effects to help with their symptoms.
Okay, thank you. Dr. Spencer Prince is following up with a question for you. The role of food sensitivity test, example, the ALCAT test.
Yes. So I use ALCAT rarely. I find it's more confusing than anything. So for those of you who don't know, the ALCAT is a blood test that looks at food sensitivities, and it'll give you a 20-page printout of 3 columns that has mild, moderate, and severe. The problem I found with the ALCAT is that it has so many things on it that people have never ate in their life. Or it has things on it that people eat every single day and have never had a problem. So, it'll have pumpernickel and raspberries and pumpkin and all these other things, and they say you have this severe allergy, and then people don't really eat these things. Or it will have 25 things in the moderate category, and it confuses the patient. Now, and when I just don't have an answer, and the patient has other allergies, I will use an ALCAT. And if there is something in the severe category that shows up that maybe the patient has on occasion, I will say, let's kind of cut these things out and see what happens. Um, it can be useful, I guess, for out in the community when you're looking for an answer. You just have to kind of take it with a grain of salt that it can be very confusing for the patient and also frustrating for you to have people eliminate all of the things that may come up in your severe, moderate, and mild category.
Okay, thank you. Dr. Bassett would like to know, is breath testing for H. pylori readily available, especially for the children?
Yes. So breath testing can be done by anybody. In Dr. Carter's study in 2012, I think he used breath testing. So yes, it's available. The GIs all have it. The test takes about 10 minutes. The person cannot have anything to eat or drink for an hour before. You breathe into a machine. It calibrates, your breath gas levels. Then you drink a solution, and then you breathe into the machine again. And if a urease reaction is present, which produces a gas that can be measured, you get a result right away. And so this is very helpful to get an immediate answer as to whether you should, particularly a child, like subjecting a child to 2 weeks of antibiotic therapy is kind of harsh, so that it helps a lot. And I've seen, just a side note, some of the highest readings that I've gotten are from people who have wells. And nobody drinks well water, but you brush your teeth with it, you use it to cook, to rinse out your glasses and stuff like that. So I always ask about wells or proximity to wells and people's history when I get these really high H. pylori readings, because I think that our water supply, at least for people with wells, is contaminated.
Okay, thank you. Dr. Philippe says great presentation and needful. Dr. Tasneem, thank you for the excellent presentation. You have mentioned we don't need to test to confirm treatment. If we don't test, how do we find resistance to treatment and to go forward with triple therapy if resistant to quadruple therapy?
That's a great question. Um, I would say that if people, and I think the guidelines support this, I have to go back and check it out. But if symptoms improve in people who are at low risk for gastric cancer and have not been diagnosed with peptic ulcer disease, confirmatory testing is not necessary. Now, you're absolutely right about our resistance patterns, and Dr. Edwards and I had a discussion about this just yesterday, about doing some cultures to see what our H. pylori looks like, and as far as resistance is concerned. It is expensive particularly in the public setting. It is expensive to get breath testing on all of these patients who you will identify with H. pylori. And I'm not so sure how readily available the stool antigen testing is. If it is readily available, particularly if your patient's symptoms persist, then yes, you want to know, did we get rid of this bug? And I guess it's probably reasonable if you're going to continue to use a triple therapy because it's easy. You want to know if your patient has H. pylori that is antibiotic resistance. But I don't think it's recommended for everybody. But if you send me an email or a text, I will follow it up to see what the guidelines say.
Okay, we have a few more comments and questions. Dr. Hannah, in your practice or experience, is there an increased incidence of functional dysplasia in diabetics? Not sure if she meant dyspepsia. And what is the association with gastroparesis?
Yeah, so functional dyspepsia and just your average diabetic, I don't think is any higher than in any other population. Um, Patients who have gastroparesis are usually your very severe brittle diabetics. I cannot say that I've seen a lot of diabetic patients presenting with real gastroparesis. We don't have the ability to really check properly for gastroparesis. You would want to get a gastric emptying stomach, which means nuclear medicine and having the patient eat something that's been tagged, and then looking at their gastric emptying times. We don't have that. And a barium study does not suffice because it's a liquid phase kind of a study. But what I can say is that I don't see it a lot, real gastroparesis. When I do consider gastroparesis is in a patient who has persistent reflux, despite being on a PPI, the recommendations are that you try to add a prokinetic. Motilium is probably the easiest with the least amount of side effects compared to Maxilon or some of the other ones. And some of these patients will improve by adding some prokinetic agent. But I do not, to answer your question, I don't think we have a high incidence of diabetics that have gastroparesis that's causing their functional dyspepsia.
You, Dr. Major. Great presentation. When taking a social history involving marijuana, does smoking versus ingesting make a difference in dyspeptic symptoms? And he also adds that you are about to be public enemy number one. If you identify the crabs as a vector for H. pylori, his wives would have to find something else to give fathers on Father's Day.
Give them grouper or snap or lobster. And again, like this is a personal theory, but I'm telling you, I'm going to come back with the information and it's going to be groundbreaking and I'm going to publish it. Anyway, so we'll see, Don. I'll keep you posted. As far as cannabis is concerned, most of these people who have GI symptoms have it from smoking. When you take a cannabis history, particularly in somebody who's and a lot of these patients get admitted, right? Because the nausea and vomiting and abdominal pain is so bad that they get this cannabis hyperemesis syndrome. When you're taking your cannabis history, one, you want to know if they smoke or ingest. Two, you want to know how often. And three, if you're really interested, you want to ask them if they smoke foreign weed, which is what everybody knows it as, has very, very high potency THC. And this is what seems to get people the sickest and give them the most symptoms. The regular stuff that's grown locally seems to be okay, but this foreign weed is a problem. People who ingest, the gummies and stuff like that, they tend not to do that on a daily basis. People who smoke weed will smoke 2 or 3 or 4 joints a day. And those are the people who are more likely to have symptoms, as opposed to the weekender who will take an edible or a gummy or chocolate, just because they're hanging out. So, and they'll know, like, if you do it and you get sick, then that's the problem. But the people who smoke weed every day are the ones who are least likely to associate their symptoms with the ingestion of marijuana.
Okay, thank you. And Dr. Carroll says, thank you for this presentation. What are your patient management recommendations when testing is not readily available
Yeah, I would say go ahead and treat. Prevalence rates,
or the patient has financial constraints?
I would say go ahead and treat. You can't be faulted for treating given our high prevalence rates. And think about it now. We're talking about some of the highest in the world as far as published data is concerned. You can't go wrong with making an assumption that perhaps these patient's symptoms are related to H. pylori. You've excluded all the other potential causes of gallbladder disease and malignancy, and you've done a thorough history and you've eliminated some of these medications, patients still having symptoms, then yes, it is absolutely reasonable to go ahead and treat them empirically. And I would encourage people to start to make the switch. We've been treating for H. pylori the same way for decades, and it's hard to remember, but write it down, keep it in your office so that you can remember the constituents, remember the Pepto-Bismol is 15 mils for that amount of time. And I think it's wise. So yes, I would advise people to do that.
Okay, Dr. Bullock says, good morning. Very timely and excellent presentation. Have you seen a better response using the 2024 updated guidelines?
I only started using them like a week ago. So, so you got to get back to me. Give me like 6 months and I'll let you know. Matter of fact, I'll probably start to try and document that so I have some data that I can present at another time. But I don't have enough experience yet to be able to answer that question properly.
Okay, now final question. What is your recommendation for a national policy associated with connections with our Bahamian diet and dyspepsia?
That's an excellent question as well. So I know after speaking to Dr. Sharita Moxie that we have and I don't remember the exact name, but it's like the healthy lifestyle something bill or act. So a lot of you, and including myself, didn't know that the government has passed a bill that will allow them to identify unhealthy ultra processed foods and sugary sweet beverages. And by identifying them, and the bill, I don't think it has a ton of teeth, but it's the beginning of a process where we can at least say these foods are bad. We want to start to educate people about the harmful effects of these foods on a consistent basis. I think there needs to be a national policy about what we give our kids. When you go to these schools and you see what they're serving in the cafeteria, when you see these kids walking to school, and every school has somebody with a car parked outside with their trunk open, and these kids are starting off with Coke and Gumbe Punch and candy and foolishness, and that's how they start their day, right? We have the government is bearing the brunt of the poor health of the country, and in my opinion, in some ways, because we're not directly doing something about it, silence is consent. And the government is footing the bill with these patients when 30 years later we have this diabetes complication rates that are crazy in the Caribbean, and we have this enormous burden of hypertension and diabetes and kidney failure and dialysis. And these are lifestyle problems. And you can't just tell people eat healthier when you have fast food chains that are doing more business in the Bahamas than they do anywhere in the globe, right? You can't, you're not going to have the outcomes that you're looking for. And the government is going to have to keep spending money because Bahamians are sick and getting sicker. And we're just allowing the bad foods and stuff to thrive. So there is a policy. Um, how much traction they're going to get with that? I mean, I was told that, even passing that bill was they had to fight tooth and nail, and they had to water it down a bit just to get it passed because you don't want to offend people. I think the time of offending people is over. If it's bad for your health and the government is paying for it, you got to make some hard decisions. And I think personally, soda should be $5 a can. I think sausages should be $25 a pound. And if you want it, then you pay for it, right? But it will curb your appetite. Water should be 50 cents a bottle, and soda should be $3 a can. It should be like that. Tampico should be $100 a bottle. So I think that there's a lot of things that the government can do that will, and you got to start from early. Once that palate has been formed and people, that desire is there, they could be in the hospital on drips, and they will have somebody bring them some KFC. They just don't understand it. So the government has to take over to some point and try to steer people towards healthier choices so that the Bahamas is not such a sick country. We're a very sick country. We are the third most obese country in the world. In the world. So I think we got a lot of work to do.
Well said, Dr. Cooper. Very well said. And it is with that that we will end our question and answer session. I thank you so much, Dr. Cooper, for joining us this morning and providing this very, very informative. Oh, someone is coming in with.
Can I also ask everybody on this call, keep the crab comment thing just between us. Don't let that go public yet until I have some more information.
Definitely, definitely. Okay, Dr. Darvel is just getting in there. If we don't be proactive, the insurance companies will.
Absolutely.
Okay, so thank you so much, Dr. Cooper, for taking the time out this morning to present this very informative and timely presentation to us. I do believe that our colleagues have been enlightened and will be using the information that you would have presented today to treat the patients that we serve. To all of my colleagues that are still on the line, thank you so much for taking the time to join us this morning. Please ensure that you complete the feedback survey and to also go back and complete the feedback survey, watch the videos for the other presentations that we have done for the year. Please note that this will be our last CME session until September. The Department of CME will be going on summer break, and I hope that you would have enjoyed all of the wonderful presentations that were brought to you thus far. While you are on break, I encourage you to continue to find other learning opportunities during the summer to keep those brain cells fired up and ready to go. So I thank you all once again for joining, and I will see you guys again. Have a great day.